Welcome, guys. Today we'll be looking at the clinical course of labor and its stages. We'll be using the outline learning objectives, introduction, clinical picture of labor, stages of labor, physiological effects of labor, active management of normal labor, antenatal preparation, first stage of labor, second stage of labor, third stage of labor, fourth stage of labor, care of the newborn, and conclusion. By the end of this lecture, you should be able to describe the onset of labor and theories behind it. Describe clinical cause of labor and its stages. Describe active management of labor as well as describe care of the newborn. So labor is the process by which a viable fetus, that's a fetus at the end of 28 weeks or more, is expelled or is going to be expelled from the uterus. Delivery means actual birth of the fetus. So labor and delivery are not same. While labor is the process of expelling a fetus out of the uterus, delivery is the actual birth of the fetus. So we'll be looking at normal labor. The following criteria should be present to call it normal labor. First, it should be spontaneous in onset. It should not be induced by any known means, chemical, mechanical, or by the use of drugs. Secondly, it should be of a singleton fetus. So a labor can only be considered to be normal if the woman is carrying only one fetus. Third, it should be at term, that's 37 to 42 weeks gestational age. Fourth, it should be presented by vertex or cephalic presentation. This is a form of presentation in which the baby or fetal head is the presenting part, and it is the best form of presentation. Fifth is through the birth canal. So the baby must be delivered through the birth canal via the vagina and not through a cesarean section within a reasonable time, not less than 3 hours or more than 12 hours. Seventh, it should be without complications to the mother nor aid to the fetus. Ninth, it should be with minimum or no intervention. So we are now looking at the cause of onset of labor. It is unknown, but the following theories were postulated. First is hormonal factors. Let's begin with estrogen theory. During pregnancy, most of the estrogens are present in a binding form. During the last trimester, more free estrogen appears, increasing the excitability of the myometrium and prostaglandin synthesis. So during the early stages of pregnancy, that's during the first and second trimester, estrogen is binded to receptors and not free. But during the last trimester, estrogen is free, resulting into excitability of the muscular layer of the uterus known as myometrium, and also there is increase in prostaglandin synthesis. And you know what prostaglandins do, they increase or cause contraction of the uterus. So next is progesterone withdrawal theory. Before labor, there is a drop in progesterone synthesis, leading to predominance of the excitatory action of estrogen. So you know progesterone is the pregnancy hormone, and it reduces the effect of estrogen. Now, just before labor, there is a drop in progesterone synthesis. This will result into the unopposed action of estrogen, causing the excitation of the uterus. Third is prostaglandins theory. Prostaglandins E2 and F2A are powerful stimulators of uterine muscle activity. Prostaglandin F2A was found to be increased in maternal and fetal blood as well as the amniotic fluid late in pregnancy and during labor. So prostaglandin F2A specifically, which is a stimulator of uterine muscle activity, was found to be increased in maternal and fetal blood as well as the amniotic fluid, in the third trimester of pregnancy and during labor. Hence, it is suggestive that it has a role to play in the onset of labor. Fourth is oxytocin theory. Although oxytocin is a powerful stimulator of uterine contraction, its natural role in onset of labor is doubtful. The secretion of oxytocinase enzyme from the placenta is decreased near term due to placenta ischemia, leading to predominance of oxytocin's action. So, oxytocinase enzyme, which breaks down oxytocin and reduces its activity on the uterine smooth muscle. During the third trimester of pregnancy, its secretion is reduced as a result of reduced or absent blood supply to the uterus. This allows oxytocin to play its role uninterrupted, hence causing the contraction of the uterine smooth muscles. So fifth is fetal cortisol theory. So increased cortisol production from the fetal adrenal gland before labor may influence its onset by increasing estrogen production from the placenta. So here, increased cortisol production from fetal adrenal gland before labor influences the onset of labor by increasing estrogen production from the placenta. Let's move to mechanical factors. So first is uterine distension theory. Like any hollow organ in the body, when the uterus is distended to a certain limit, it starts to contract to evacuate its contents. This explains the preterm labor in case of multiple pregnancy and polyhydramnios. So most hollow structures in the body, when they are expanded or distended to some extent, they start to contract in order to get rid of its contents. Now, this explains why there is usually preterm labor in pregnancies carrying more than one child and polyhydramnios, that's excessive amniotic fluid. So second is stretch of the lower uterine segment by the presenting part near term. So during the late stages of pregnancy, there is stretching of the lower uterine segment, that's the area around the cervix and the cervix itself, by the presenting part. So this also has a role to play in the onset of labor. So let's look at the clinical picture of labor. So A is the prodromal or pre-labor stage. The following clinical manifestations may occur in the last weeks of pregnancy. First is shelving. It is falling forwards of the uterine fundus, making the upper abdomen looks like a shelf during standing position. This is due to engagement of the head, which brings the fetus perpendicular to the pelvic inlet in the direction of pelvic axis. So shelving in pregnancy or labor means that when you look at the mother's belly, you can see or feel a step or ridge across it like a small shelf. This is what happens. The baby's head is stuck and can't come down, usually because it's too big or the pelvis is too small. The top part of the womb, that's the uterus, keeps contracting strongly while the lower part becomes thin and stretched. This creates a visible line or ridge between the two parts. That's what is called the shelf. So second is lightening. It's the relief of upper abdominal pressure symptoms as dyspnea, which is difficulty in breathing, dyspepsia, which is pain around the upper abdominal area, and palpitations, which are noticeable heartbeats due to descent in the fundal level after engagement of the head and shelving of the uterus. So third is pelvic pressure symptoms. With engagement of the presenting part, the following symptoms may occur. First is frequency of micturition. This is increased number of times of urination. Second is rectal tenesmus. This is the persisting urge to defecate even though the rectus is empty. Third is difficulty in walking. Fourth is increased vaginal discharge. So fifth is forced labor pain. These are differentiated from true labor pain as follow. True labor pain is regular, while forced labor pain is irregular. True labor pain increase progressively in frequency, duration, and intensity, while forced labor pain do not. True labor pain is felt in the abdomen and radiating to the back, while forced labor pain is felt mainly in the abdomen. True labor pain causes progressive dilatation and effacement of the cervix, while in forced labor pain, there is no effect on the cervix. In true labor pain, membranes are bulging during contractions, while in forced labor pain, there is no bulging of membranes during contractions. True labor pain is not relieved by antispasmodics or sedatives, while forced labor pain can be relieved by antispasmodics. So antispasmodics are drugs that are used to relieve or stop muscle spasms.